So we're going to wrap up with tumors. This is going to be a little bit shorter, and I'm going to try to add in a little bonus material that I think is fun. But we're moving now way outside the space of evidence-based medicine, and we're going to be firmly talking about retrospective series and really best practice. But there's going to be none of this level 1 data as I related to aneurysms or certainly to ischemic stroke in this space. So, but we deal with tumors, and I think this is an area that neurointerventional imaging and endovascular treatments will enlarge over time. But most of what we do are dural-based lesions. We'll talk about those first, but then we have some other types of lesions that we treat. But largely what we're trying to do with most tumor treatment is reduce blood supply. Just as the same mentality that we deal with AVMs is to try to make surgical resection easier, it's the same kind of rationale as it relates to these tumors. So meningioma is far and away the most common disorder that we'll treat, or tumor we'll treat. It's the most common intracranial tumor. Again, it affects older patients. There is a female bias, and it does have some hereditary symptoms that are associated with it, but largely they're sporadic. Patients who receive some sort of ionizing radiation at high levels will have a higher rate of meningioma formation. There's been a lot of study in this in terms of small retrospective series. This is a study that we actually did here at UCSF, looking at the roles for MR perfusion in combination with angiography to better understand the blood supply to tumors and how embolization can impact how those tumors behave. And this is kind of the classical picture you get with a meningioma, and this is why angiography has been around much, it predates CT and all these other cross-sectional images. And so this is how they used to diagnose tumors, obviously, is to look at how the brain was splayed and where it was splayed relative to these tumors to make a determination as to what they were dealing with before they went into the OR. But what you can see here is this splaying of the anterior cerebral vessels, the middle cerebral vessels, and this paucity of what we call, brain blush. And so this is related to a meningioma. This is the dural supply to it. And so you see these enlarged middle meningeal branches, which come up and have this very hypervascular blush that then persists into the late arterial phase. The classic, what they call mother-in-law, it comes early and stays late appearance. I have nothing bad against mother-in-laws, but that's just the phrase that is often used. And then this is what it looks like after you embolize it. We typically use a combination of particles and sometimes with coils to kind of reduce the blood supply to these tumors. And this is what this looks like. So this is what the lesion looked like before we treated it. So it has a lot of avid enhancement. And this is what it looks like after embolization. So you can see there's a big area of the devascularization. And what this does is, in addition to helping blood supply or reducing blood supply, it can actually help the tumor shrink a bit, and they can increase the dissection planes or the space between the brain and the tumor to help ease resection. So in addition to doing things where we're just trying to reduce blood supply, we can actually primarily treat tumors. And this is an area that I think, people have looked at the idea of treating things like GBMs and other types of CNS lymphoma using different types of intraarterial agents. This is one where we're really made quite a bit of headway. So retinoblastoma is a disorder, a pediatric disorder, and affects obviously the retina, but it's been historically treated using systemic chemotherapy. Sometimes in very distant past, people use external radiation, but obviously they found that was very injurious to children long-term, and then enucleation, of course, for advanced disease. But more recently, people have found that by harnessing the ability to catheterize the ophthalmic artery, you can deliver extremely high doses in a very low concentration of chemotherapeutics. We largely use melphalan, which is a very, very toxic drug, but we use such a small amount, it allows it to be very potent in its effect to the target organ. This is a paper we published just talking about how to reduce radiation exposure in these delivery methods. And so this is another, again, I mentioned that parametric color coding. This is that same type of technology. What we're looking at here is trying to better understand, as you have collateral inputs, so this is the meningolacrimal component off of the external carotid artery that communicates with the ophthalmic artery, how those impacts or how they dilute the chemotherapeutic as it goes to the choroid. Here's the choroidal blush, and then how that affects outcomes. In addition, now moving back to areas where we have tumors that bleed but are not undergoing like a definitive treatment through the blood vessels. The nasopharyngeal angiofibroma happens again in younger populations, but here is just shows the dramatic destruction that these tumors can have at the skull base. They seat themselves typically arising from the pterygopalatine fossa, but then they can obviously grow in an uncontrolled fashion up into the skull base and obviously all throughout the nasal pharynx. This is what these look like on angiography. So here's a hypervascular blush from the external carotid supply. This is the internal maxillary artery. This is a lateral projection, AP projection. And then here it is from the ICA. So you can see here there's branches of the median and mandibular arteries, which come off the petrous segment of the ICA, which can also feed these tumors. Ultimately, again, we can block off the blood supply. It doesn't look very, very interesting, but what this does is translates into hopefully a better resection for that patient. Another type of tumor, again, a very hypervascular tumor, are the carotid body or the paragangliomas that happen in and around the skull base and peripheral nerve sheaths. And so here is a hypervascular tumor. Here it is with contrast, splaying the internal external carotid branches, typical of a carotid body tumor. And here it is an MRI projection, just opening up those two vessels. Here it looks like in angiography, and so here's this hypervascular blush. These are most often fed by the branches of the ascending pharyngeal artery, but they can pick up small perforators or other branches off of the proximal ICA and ACA. But again, this just makes the tumor resection safer and easier. So last but not least are actual osseous tumors. This is a paper we published a few years ago looking at the role of spinal tumor embolization, and this is just kind of all pathologic types. Most of these were renal cell carcinoma mets, but ultimately what we found is that depending on the sufficiency or the completeness of that embolization, again using PVA, it does impact blood loss, which does impact clinical outcomes. So here's an example. Here's a patient who has a very abnormal chest x-ray, and the corresponding CT and MR image is just showing this very expansile heterogeneous mass at the costovertebral junction. This was a giant cell tumor, which can be very vascular. And here is the corresponding angiogram. So obviously spinal angiography is a part of our practice, both for actual intramedullary lesions, but also things outside the spinal cord, as in this case. But here you can see this very, very vascular tumor, both from below and above. And here's what it looks like, obviously, after we embolize it. But again, that translates into a better resection for the patient. So I'm going to pause here just for a second